Good morning, everybody. Today I'm going to present my seminar by the topic The Paris System for Reporting Urinary Cytology. I'll be dealing under the following headings: Introduction, Specimen Collection, Processing, Normal Elements seen in the urine cytology, the Paris System for Reporting, Summary, and References. Firstly, introduction. Urine cytology was popularized by George Papanicolaou in the 1940s as a way to detect and follow patients with bladder cancer. Despite many attempts to develop another test with greater sensitivity and specificity, cytology remains one of the best ways to diagnose a variety of bladder lesions, most importantly, high-grade urothelial carcinomas. The reporting system for urine cytology has evolved over a period of time according to the changes in the histopathology classification. Initially, Dr. Papanicolaou suggested a reporting system which included 5 classes. Although it had a great role in diagnosing high-grade urothelial carcinoma, the definition and criteria for each category were somewhat unclear. On the basis of the histopathology classification of bladder cancer by the WHO classification in 1973, Kos et al. Reported a new classification system. In this system, the high-grade urothelial carcinoma was characterized by the presence of hyperchromasia and nuclear membrane abnormalities in the malignant cells. After changes in the WHO classification, the Papanicolaou Society of Cytopathology, that is PSC task force, also reported a diagnostic classification system for urine cytology similar to the 2001 Bethesda system for reporting uterine cervical cytology. The Papanicolaou Society of Cytopathology scheme identified 3 different and simplified categories. They were negative, positive, and an equivocal category, which was called atypical urothelial cells. Urine cytology is more sensitive in detecting high-grade urothelial carcinoma than low-grade urothelial neoplasm. The importance of tumor grade as a prognostic factor. Tumor grade is a strong prognostic factor. It has a higher predictive value of tumor progression and mortality than tumor stage. High-grade urothelial carcinomas generally has a worse prognosis than low-grade urothelial neoplasm regardless of the stage. The stage progression and mortality of urothelial carcinomas are noted in as many as 65% of patients with high-grade urothelial carcinomas. Clinical indications for urine cytology. Hematuria is the first indication. The second indication is as a follow-up in patients who are previously treated for urothelial carcinoma because the risk of recurrence is high. And high risk of bladder cancers in a population like occupational exposure to aniline dyes, aromatic amines, cyclophosphamide treatment for diseases like multiple sclerosis. Coming to specimen collection. There are 6 ways of specimen collection: voided urine, catheterized urine, bladder washing, upper tract washing, brush cytology, and ileal loop. Voided urine, this is obtained 3 to 4 hours after the patient has last urinated. The first morning voided urine specimen should be avoided for cytology because the stagnant cells in the low acid-base balance and hypertonic environment undergo degenerative changes, making cytologic assessment very difficult. The catheterized urine, the risk of urinary tract infection, pooled specimen that has been at room temperature for many hours undergoes cellular degeneration. The tip of the catheter often scrapes off benign urothelial cell clusters which mimic appearance of a low-grade papillary neoplasm. Bladder washings. This is obtained by irrigating the bladder with 5 to 10 pulses of 50 ml of sterile normal saline, which produces a cellular suspension of freshly exfoliated epithelial cells. This is done for better cellular preservation. There is greater cellularity and less chance of contamination by background debris. Upper urinary tract washings and brushings. This method is preferred in cases of upper urinary tract malignancies. Ileal conduits. At the time of cystectomy for bladder cancer, a segment of ileum is isolated and re-anastomosed to the ureters to provide a conduit for urine. The urine samples from these conduits contain a large number of degenerated intestinal epithelial cells. This is used for screening for recurrence of bladder cancer. Now coming to processing. The fresh specimen between 1 and 12 hours old do not need any fixation. If the specimen requires 12 to 24 hours to reach the laboratory, then refrigeration is recommended. If it requires more than 24 hours, preservation of the urine sample can be done by adding equal volume of 50 to 70% ethanol with 2% carbovax to avoid degeneration of the cells. The slides can be prepared using concentration techniques, sedimentation and smearing, membrane filtration, cytocentrifugation and thin layer methods. These slides are fixed in ethyl alcohol and stained with pap stain. Urine samples and bladder washing can also be prepared using the cell block technique. The centrifuged sediment is fixed in formalin and the slides are stained using HND. Normal elements seen in the urine cytology. The urothelial cells, which can be intermediate and superficial, that is umbrella cells. These are mostly seen in the voided urine. The intermediate, superficial and basal cells, these are seen in the catheterized urine or bladder washings. We can also see squamous cells, seminal vesicle epithelial cells and degenerated intestinal epithelial cells in cases of ileal conduit specimens. This is the picture of urothelial or transitional cells which are dispersed as isolated individual cells. Tight clusters are not common in a normal voided urine sample. In voided specimen, most urothelial cells are intermediate in size with a moderate amount of homogeneously granular or finely vacuolated cytoplasm, round nuclei and small nucleoli. In some cases, they are columnar or spindled. This is a normal finding. The reason for these shapes is not known. The degenerated urothelial cells resemble histiocytes. They contain round red or green hyaline cytoplasmic inclusions. These are called as Melamed-Wolinska bodies. They are seen in almost 50% of urine specimens. They do not have any diagnostic value in urine. They are useful in suggesting a urothelial origin for malignant cells in cases of pleural effusions. The umbrella cells are large with abundant cytoplasm and large nuclei. Binucleation and multinucleation are common. They have low NC ratio, which helps to distinguish them from the cells of urothelial carcinoma. Squamous cells are commonly seen. They exfoliate from the foci of squamous metaplasia in the trigone of the bladder. If the urine is contaminated by cells from the vagina, also these cells can be seen. Catheterization mechanically abrades the mucosal surface, resulting in large number of cells in fragments. The entire spectrum of basal, intermediate and superficial cells are seen in this picture. Here we can see the small basal urothelial cells because of their scant cytoplasm and dark nuclei, and they are occasionally mistaken for carcinoma cells because of the scant cytoplasm and darkly stained nuclei. They have round regular nuclear counters when compared to the malignant cells which have irregular nuclear counters. Seminal vesicle epithelial cells. These are seen in urine samples obtained from male patients. They sometimes have hyperchromatic nuclei and they can be mistaken for malignant cells. The clue to their benign nature is the presence of lipofuscin, a golden brown cytoplasmic pigment. The intestinal epithelial cells in ileal lobe specimen are dispersed as isolated cells and show marked degenerative changes with eosinophilic intracytoplasmic inclusions. Here we can see the inclusions such as those seen in the degenerated urothelial cells. They are commonly mistaken for macrophages. The crystals can also be seen in this kind of specimen. Occasionally RBCs, red blood cells are commonly seen, but the presence of many red blood cells is also abnormal. Bacteria and candida are common without concomitant inflammation or clinical significance. Now coming to the Paris system for reporting urinary cytopathology. The Bethesda system cervical cytology terminology effort initiated in 1988 led the way for standardized reporting in any cytopathology. It addressed specimen adequacy, correlated morphology with the biology of disease processes, lumped biologically equivalent entities and recognized the necessity to improve inter-observer reproducibility of the equivocal category of Ertypia based on histopathology and clinical outcomes. It has achieved widespread international acceptance leading to standardized terminology, corresponding management guidelines and to funding of research. The Bethesda system has been the model for subsequent development of standardized cytopathology reporting. The idea of developing the Paris system for reporting urinary cytopathology was conceived during the International Academy of Cytology Congress held in Paris in May 2013. Doctors Rosenthal and Wojcik have led the Paris system of working group. They have included international members so that global acceptance of the terminology would be immediately implemented. Consensus was built by frequent emails and conference calls for each of the 10 groups. The entire working group consisted of 49 members, 28 from 12 United States and 21 from 9 countries including Canada, France, Italy, Japan, Korea, Luxembourg, Slovenia, Switzerland and the United Kingdom. The examination of urine for the diagnosis of human disease is ancient. Its use for the detection of neoplasms of the urinary tract came long before histology. Diminished prevalence of urinary cytology for the detection of most bladder neoplasms results primarily from two factors: the traditional definition of malignancy and the insistence of clinicians on labeling all urothelial neoplasms as bladder cancers. Urothelial malignancy, in contrast to grading, has not been defined on the basis of the degree of anaplasia of the component cells, which in other systems is considered a hallmark of malignancy. Coming to the pathogenesis of urothelial carcinoma. The main goal of urinary cytology is the detection of urothelial carcinoma that is clinically significant, namely high-grade urothelial carcinoma. There are two pathways of neoplastic transformation of urothelium. The urothelial carcinoma has two distinct pathogenic pathways, a hypoplasia pathway and a dysplasia pathway. A third pathway which shows the molecular abnormalities of both hypoplasia and dysplasia pathway is also known. The hypoplasia pathway is more common, accounting for about 80% of cases, and starts with urothelial hypoplasia that progresses to low-grade papillary urothelial carcinoma. Here we can see this is the normal urothelium. There are two pathways, the papillary pathway which is most common and it accounts to 80% of the total cases. Here we can see deletion of CDKN2A on chromosome 9 as well as mutation in FGFR3 genes, and this is a genetically stable form. Here we can see the hypoplasia of the urothelium which gradually progresses to low grade carcinoma. It has a high rate of recurrence. When this includes RAS mutation, it converts itself into high-grade carcinoma. The non-papillary pathway accounts for 20% and it depicts itself with dysplasia. It is genetically unstable and few cases, approximately 60% of them, show P53 mutation. Those cases which show P53 mutation directly go into high grade carcinoma, and a few percentage of this dysplastic urothelium go into carcinoma in situ, which finally goes into invasive carcinoma. In high grade carcinoma also there is high rate of recurrence. This could potentially indicate that these two pathways are completely separate from each other. Low-grade carcinoma and high-grade carcinoma may represent two entirely different diseases. Truly clinically significant urothelial neoplasms are the ones that have the ability to invade deep muscle. These are high-grade urothelial carcinomas. Negative for high-grade urothelial carcinoma. The negative category includes reactive changes, infections and non-neoplastic conditions, cases that may have some cytologic features of low-grade urothelial neoplasms but are negative for high-grade urothelial carcinoma. The Paris system includes categories of atypical urothelial cells and suspicious for high-grade urothelial carcinoma as well. It is of importance in the understanding that the difference between the two categories, suspicious for high-grade carcinoma and positive for high-grade urothelial carcinoma, are quantitative, since the diagnostic features for these two categories are based on simple morphological findings. The Paris system of Paris system of reporting urinary cytology book gives a very important chapter on adequacy of specimen. This is to frame the sampling of the urinary tract numerically. A healthy average maximally distended human bladder has an approximate value of 600 ml. Approximating a spherical shape, the inner surface area of that bladder would be approximately 350 square centimeter. The average urothelial cell has an approximate diameter of 20 micrometer or a two-dimensional surface area of 314 square micrometer. The urothelium is about 5 cells thick, so the total number of urothelial cells lining the bladder is in the order of 108 to 109 cells according to the calculation. Thus, even a highly cellular urine specimen contains only a small fraction of urothelial cells lining the bladder and may contain no or very few abnormal cells. This is a flow chart provided by the book. If there are atypical, suspicious or malignant cells, the specimen is considered as adequate specimen. If it is an instrument, if there are no atypical, suspicious or malignant cells and it is an instrumented specimen, we should look for benign urothelial cellularity. If it is present, it is adequate. If benign urothelial cellularity is not present, it goes into inadequate specimen. If there are no atypical cells and it is not an instrumented specimen, we should look for non-urothelial features like vaginal epithelial cells, features that obscure urothelial morphology. If these features are not present, we should look for benign urothelial cellularity, and if those are not present, if they are present, then it goes into adequacy. If the benign urothelial cells are not present and there is adequate volume, then it is adequate specimen. If the adequate volume is not there, then it is inadequate specimen. And if the non-urothelial cells are present, then it goes towards inadequate specimen. The Paris system of urinary cytology subclassifies the diagnosis into 5 categories. Firstly, negative for high-grade urothelial carcinoma, which is considered as negative. Atypical urothelial carcinoma. Third is suspicious for high-grade urothelial carcinoma, that is suspicious cells, and high-grade urothelial carcinoma, and the fifth part is the last part, that is a low-grade urothelial carcinoma. Firstly, negative for high-grade urothelial carcinoma. All entities that pose no significant risk to the patient for developing high-grade urothelial carcinoma are included. If any of the following components are present in the specimen, it is considered as negative for high-grade urothelial carcinoma. The benign urothelial glandular or squamous cells, benign urothelial tissue fragments and urothelial sheets or clusters, changes associated with lithiasis, viral cytopathic effect like polyoma virus, post-therapy effect including epithelial cells from urinary diversions. Firstly, benign superficial or umbrella urothelial cells. The cytoplasm of large superficial cells is very frothy and abundant, resulting in a low NC ratio. The nuclei are pale, finely granular chromatin. They have prominent nucleoli, but they do not reflect any abnormality. In case of instrumentation, multinucleation is common. There are clusters. Here we can see there are clusters of smaller cells which are seen. Here the nuclei are round, darker and slightly smaller. The nuclear membranes are smooth and architecture is uniform. They have high NC ratios, but they are not considered as malignant cells. Umbrella cells. These are the most superficial cells in the bladder, creating an umbrella over all other urothelial cells. They have a thickened cytoplasmic edge that does not go all around the cell. You can see in this cell there is a thickened cytoplasmic edge all around, but here it is absent. This constitutes the asymmetric unit membrane, providing a barrier between the toxic urine and the blood. Now coming to intermediate urothelial cells. The intermediate layer of urothelium immediately underneath the umbrella cells is easily dissociated into single cells. They often have cells with tails. Here we can see many cells which have cells with tails. These are the intermediate urothelial cells. Reactive umbrella cells. These are most inflamed epithelial cells which demonstrate changes. Here we can see the nucleoli are prominent, but nuclear chromatin is finely granular and the shapes are round and regular. The cytoplasm has retained its transparency. Here we can see the cytoplasmic transparency is retained. Inflammation is seen in the form of neutrophils as well as lymphocytes. Changes as consistent with epithelial repair are identical with those in all other body sites. Epithelium reappears stretched, but all cells stay connected, retaining their intracellular connections. Here we can see all the cells are together and they all are, this implies that they all have retained the intercellular connectivity. Glandular cells. Cystitis cystica or glandularis. Glandular cells from the lining of the bladder can originate from the urothelium, metaplasia from an inflammatory focus, cystitis cystica or glandularis, or from a glandular neoplasm, either primary or secondary. Cystitic cystica may appear as a single layer of glandular cells. They closely resemble endocervical cells and could be from a case of endocervicosis if the tumor was also in the muscular wall of the bladder or ureter. Another tight glandular group of a tissue fragment demonstrate nuclear compression by relatively large cytoplasmic vacuoles. Regardless of their origin, these cells fulfill the criteria of benignity, making the diagnosis of negative appropriate. Renal tubular epithelial cells, there are two types, that is histiocytic type and glandular type. The histiocytic type, here the cells are very small and they have a size of histiocytes. They may have vacuolated cytoplasm in varying amounts and may occur singly. They are scattered singly, here we can see. When aggregated, a cast should be considered, implying renal disease. Renal tubular epithelial cells, glandular type. They represent a tubular cast. The renal tubular cells vary from small with scant cytoplasm to large and vacuolated. Now coming to the next entity, that is the benign urothelial tissue fragment. These can be seen in voided urine and should not mandate a diagnosis of atypical. They have nuclei which are uniform in size and shape, evenly spaced with finely granular chromatin. In case of instrumented urine specimen, they are cellular, consisting of numerous benign appearing cells arranged in groups that resemble papillary clusters. Here we can see that lack fibrovascular cores. This specific case was diagnosed as suspicious for low-grade neoplasm due to resemblance to a papillary lesion. The excision of the kidney revealed only urothelial hyperplasia overlying a subepithelial hemangioma. Retrospective review recognized uniform nuclear size and round shape. Here we can see the uniform nuclear size and they all have round shape. Urothelium with nephrolithiasis. Kidney and bladder stones can cause serious changes in the urothelium, sometimes resembling neoplasm. Clinical examination of the cells in a 3D dimension is critical to an accurate diagnosis. They have round nuclei with evenly spaced, which are evenly spaced. They have finely granular chromatin and inconspicuous nucleoli. They do not have any fibrovascular stalk, which eliminates the diagnosis of a low-grade urothelial neoplasm. Calcific concretions in voided urine may be recovered in patients with history of renal calculi, which gives us a diagnosis of urothelium with nephrolithiasis. Coming to the next entity, that is the polyoma virus. This is a classic form. There can be spider web and benign case. It is a benign case. The classic changes include enlargement of the nucleus and nuclear chromatin homogenization caused by viral infection. The shape of your nucleus is always round or oval with a very smooth outline. The cytoplasm is almost gone. Here also we can see the cytoplasm is almost gone. If the focal plane is changed, then the spider web of degenerated cytoplasm comes into view. Next, coming to the atypical urothelial cells. Urothelial cells with mild to moderate cytology, which is not architectural atypia, is considered under atypical urothelial cells. If the reason for atypia is known, such as changes caused by polyoma virus and other infections, reactive umbrella cells, seminal vesicle cells and reactive changes due to stones, instrumentation and therapy, such cases should be assigned to the negative for high-grade urothelial carcinoma category. If the reason for atypia is not known, then we can consider it under the diagnosis of atypical urothelial cells. Atypical urothelial cell is defined as cellular changes that fulfill the major criteria and only one minor criteria. that is the presence of 2 or more minor criteria including hyperchromasia, is diagnostic of suspicious for high grade urothelial carcinoma unless there are marked degenerative changes. Now coming to the major criteria. Non-superficial and non-degenerated urothelial cells with an increased NC ratio of more than 0.5. The minor criteria are: there is nuclear hyperchromasia, irregular nuclear membranes and irregular coarse clumped chromatin. Atypical urothelial cells. The group at the top is composed of intermediate type urothelial cells with smooth nuclear counter and no features of atypia. The urothelial cells in the group in the bottom have high NC ratio and nuclear counter irregularity. Nuclear chromasia is seen in both the groups, but here because of the irregular nuclear counter and high NC ratio, it is considered as atypical urothelial cells. Atypical urothelial cells with high NC ratio and nuclear counter irregularity can be seen in this picture. The absence of hyperchromasia and the presence of degenerated clumped chromatin preclude a diagnosis of suspicious for high grade urothelial carcinoma. Here we can see atypical urothelial cells with high NC ratio, enlarged nuclei and mild nuclear counter irregularity. The chromatin is unevenly distributed yet hyperchromatic. The concurrent bladder biopsy showed acute cystitis with extensive reactive epithelial changes. Urothelial cells display irregular nuclear counter and variation in nuclear size. There is mild nuclear hyperchromasia. There are degenerative cellular changes such as partial loss of the cytoplasm and loss of crisp nuclear details in this picture. The follow-up of patients with atypical urothelial carcinoma, urothelial cells diagnosis has shown a wide spectrum of conditions from benign diseases such as urolithiasis, cystitis, BPH, renal disease, diabetes, irradiation, chemotherapy, immunotherapy, and indwelling catheter, post-instrumentation, papilloma, to malignant diseases like high-grade urothelial carcinoma or low-grade urothelial carcinoma. Hence, the risk of detecting a biopsy-proven high-grade urothelial carcinoma following a atypical urothelial cell diagnosis ranges from 8.3 to 37.5%. Next, coming to suspicious for high-grade urothelial carcinoma. This diagnosis is restrictively used in cases with abnormal urothelial cells that quantitatively fall short of a definitive diagnosis of high-grade urothelial carcinoma. Coming to the criteria, a diagnosis of suspicious for high-grade urothelial carcinoma is defined as non-superficial and non-degenerated urothelial cells showing either increased NC ratio, moderate to severe hyperchromasia. In addition, the minor criteria which should be at least one of the two criteria. There is irregular clumped chromatin or marked irregular nuclear membrane. So, in this the major criteria are two, that is high NC ratio and moderate to severe hyperchromasia, whereas the minor criteria are irregular chromatin and irregular nuclear membrane, whereas in atypical urothelial cells the major criteria was only high NC ratio, whereas the minor criteria were hyperchromasia, irregular membranes, nuclear membranes and clumped chromatin. The decision to assess the case into suspicious for high-grade urothelial carcinoma or the positive for high-grade urothelial carcinoma categories is based on the number of abnormal cells fulfilling the above criteria. This is the major criteria which should be used to differentiate between suspicious and positive cases. A cutoff range of 5 to 10 cells is recommended based on the degree of abnormal nuclear changes observed and the level of pathologist's comfort, by taking into account the severity of atypia of all the abnormal cells and the clinical context as well as the specimen type. Here in this picture we can see a single abnormal well preserved intermediate urothelial cell with an eccentric nucleus with increased NC ratio and hyperchromatic nuclei and irregular clumpy chromatin and mild nuclear membrane abnormality. Here we can see abnormally well preserved intermediate urothelial cell showing increased NC ratio, hyperchromasia and irregular nuclear membranes. Here we can see a single abnormal well-preserved intermediate urothelial cell showing high NC ratio, hyperchromasia, irregular clumpy chromatin but smooth regular nuclear membrane. So it fits into two major criteria and one minor criteria. There is severe hyperchromasia in compared to the normal cells, normal intermediate urothelial cell. These are the normal intermediate urothelial cell. We can compare these cells with this one atypical cell which is suspicious. Now coming to the high-grade urothelial carcinoma. In the 2004 WHO classification, high-grade urothelial carcinoma has papillary structures lined by tumor cells that are disorderly arranged and are cytologically malignant. The papillary fronts are frequently fused with each other. They are easily found at low scanning power. Pleomorphic nuclei with prominent nucleoli, loss of polarity and frequent mitosis can be seen. Carcinoma in situ is frequently observed in the surrounding mucosa in cases of high-grade urothelial carcinomas. Urine cytology cannot distinguish invasive high-grade urothelial carcinoma from non-invasive high-grade urothelial carcinoma or carcinoma in situ. However, the background in carcinoma in situ is reported to be clean without blood, abundant inflammation and cellular debris. The malignant cells usually display a NC ratio of 0.7 or greater and demonstrate nuclear hyperchromasia, irregular nuclear membranes and coarse chromatin. According to the Paris system consensus, a cellular cytologic urine specimen with a minimum of 5 to 10 viable malignant cells will qualify as high-grade urothelial carcinoma. The type of specimen and comfort level of the pathologist may contribute to the minimal number of abnormal cells required for a more definitive diagnosis of malignancy. For example, upper urinary tract instrumented specimen will require at least 10 abnormal cells, whereas voided urine, because it already has degenerated cells, whereas voided urine specimen may require a lesser number of cells to establish a definitive diagnosis of high-grade urothelial carcinoma. Because in case of voided urine specimen, apart from the first specimen, early morning specimen, the cells do not show so much of cellular degeneration. In this is a picture showing high-grade urothelial carcinoma. There is hypercellularity as compared to the previous pictures. Numerous tumor cells are present that demonstrate pleomorphism and necrosis in the background. This sample was full of abnormal cells with high NC ratio and prominent nuclear profiles. Here also we can see. This particular B picture sample stained lightly, so observers are cautioned to use normal cells in the background as stain intensity controls. The nuclear size can be compared with the lymphocytes. Here we can see the cohesive group of malignant cells. Then here the NC ratio is 0.7 and more. Here we can see the nuclear hyperchromasia and adjacent areas showing tumor necrosis, which is almost clinging next to the cells. This is the necrotic area which is clinging next to the hyperchromatic cell. The high-grade urothelial carcinoma can be again divided into two, the one with squamous differentiation and second with glandular differentiation. High-grade urothelial carcinoma with squamous differentiation. This is defined by the presence of keratinization and or intracellular bridges as classic morphologic features. The squamous cells are intermixed with malignant cells exhibiting classic features of high-grade urothelial carcinomas. The squamous cells display hyperchromatic and spindle-shaped nuclei with clumped chromatin. The cytoplasm is dense, keratinized and orangeophilic. Keratin flakes and necrosis are frequently observed in the background. The diagnosis of squamous carcinoma of the urinary tract can only be determined by extensive examination of biopsy or cystectomy tissue. Here we can see a few cells in picture A exhibit classic features of high-grade urothelial carcinoma. These cells, they exhibit classic features with high NC ratio, hyperchromatic nuclei, irregular counters, which is adjacent to the cells of squamous degeneration. In picture B, we can see pronounced keratinization of tumor cells. The diagnosis of urothelial carcinoma versus squamous cell carcinoma will depend upon the percentage of squamous differentiation once the bladder is removed and completely examined histologically. High-grade urothelial carcinoma with glandular differentiation. Glandular differentiation is defined as the presence of two true glandular formation within groups of tumor cells. The glandular cells are intermixed with malignant cells exhibiting classic features of high-grade urothelial carcinoma. Diagnosis of adenocarcinoma of the urinary tract can only be determined by extensive examination of biopsy or cystectomy tissue. In this picture, we can see high-grade urothelial carcinoma with cytoplasmic vacuolization reflecting glandular differentiation. Here we can see nuclear membrane irregularity, hyperchromasia and coarse chromatin, and we can see the cytoplasmic vacuolization which possesses towards the glandular differentiation. Here in the picture A, we can see some scattered high-grade urothelial carcinoma which demonstrate focal glandular differentiation. Here we can see tumor cells, many of them have cytoplasmic vacuolation and irregular nuclei showing glandular differentiation. The criteria of malignancy in cases of high-grade urothelial carcinoma. This is based on the following criteria. The 5 criteria are considered. The cellularity, at least 5 to 10 abnormal cells should be present. The nuclear and cytoplasmic ratio should be 0.7 or more. The nucleus should be hyperchromatic. There should be irregular nuclear membrane and coarse or clumped chromatin. The other notable cytomorphologic for a high-grade urothelial carcinoma, all these 5 criteria should be present. All the 5 criteria should be present. Other features can be cellular pleomorphism, marked variation in cellular size and shapes, that is round, oval, elongated or plasmacytoid, which is also called as comet cells, scant, pale or dense cytoplasm, prominent nucleoli, mitosis, necrosis and inflammation can also be seen. Now coming to the last grade, that is the last category, that is the low grade urothelial neoplasm. The cytologic definition. In keeping with the 2004 WHO terminology, low-grade urothelial neoplasia is regarded as a combined cytologic term for low-grade papillary urothelial neoplasm, that is which includes urothelial papilloma and flat low-grade urothelial intraurothelial neoplasia. Cytologic criteria of low-grade urothelial carcinoma. 3-dimensional cellular papillary clusters should be present, which are defined as clusters of cells with nuclear overlapping forming papillae with fibrovascular cores including capillaries. Only in the presence of this feature is the definitive cytologic diagnosis of low-grade urothelial neoplasm possible. Here we can see in the picture, in the first picture, which was diagnosed as positive for low-grade urothelial neoplasm. 3D papillary structures with central cores are seen. This is the central cores and they all are in 3 dimension. There is mild cytologic atypia and disorganization of cells forming papillae. In picture B, we can see again 3D cluster of cells with a central fibrovascular core forming a papillae. Now coming to the final summary. Here we can see if there is cytologic atypia in the urinary cytology, if it is present, and if the atypia is severe, that is nuclear cytoplasmic ratio is more than 0.7 and hyperchromasia with either coarse chromatin or irregular chromatinic rimming. If many cells like this are seen, they are considered as positive for high-grade urothelial carcinoma. If these kind of cells are less than 5 to 10 cells, it can be considered as suspicious for high-grade urothelial carcinoma. If the cytologic atypia is mild, that is nuclear NC ratio is more than 0.5 with either one of hyperchromasia or coarse chromatin or irregular nuclear membrane, if the reason for mild, if these are present and the reason for mild atypia is not known, then it can be diagnosed as atypical urothelial cell. If the reason for mild atypia is known, like urolithiasis, catheterization, polyoma, and treatment in BCG immunotherapy, etc., then it can be considered as negative for urothelial carcinoma. Now, if the cytologic atypia is not present, and we should look for fibrovascular cores. If fibrovascular cores are seen, then we can consider it under low grade urothelial neoplasm. If fibrovascular cores are not seen, we should look for other diagnostic modalities like endoscopy, radiology, and clinical impression, and we can give it as negative for high grade urothelial neoplasm. This is the summary of reporting a urine cytology based on the newly introduced Paris system of reporting urine cytology. These are my references. Thank you.